umaga. Good morning. That's Filipino for good morning. I am Dr. Pauline Convocar. I'm the president-elect of the International Federation for Emergency Medicine, and it is really my pleasure to welcome you to this important and timely session to start our day 2 of the conference. We are here for the session on toxic leadership in healthcare. And in an environment as high stakes and high pressure as healthcare, teamwork is not just important, it is really essential. Yet, even the most skilled and dedicated teams can falter under the weight of toxic leadership. So today's session will explore how certain leadership behaviors affect teams and perhaps compromise our delivery of patient care. I personally look forward to knowing what toxic leadership may look like in clinical settings, the subtle and not so subtle ways it manifests, and perhaps how institutions and individuals can respond to protect team performance and well-being. It is my great honor to introduce our speaker who will shed light on one of the most uncomfortable but necessary conversations in modern healthcare leadership. Please join me in welcoming to our stage Dr. Bruzzle, an emergency physician, educator, and simulation professional. Dr. Bruzzle.
Thank you very much for the kind introduction. And I hope this really does resonate with people. Because toxic leadership, difficult doctors, I suggest they're everywhere. And I think it's tempting to think that the problem is obvious. But maybe we don't all share a view of that. So I thought to start this off, we might have a little simulation, because I do a bit of simulation, just to sort of set the scene about what we mean when we're talking about those difficult doctors. So I want you to imagine that we're in the emergency department. We've got quite a lot of people in the waiting room, as you can see. And I'm about to refer a patient. Seems pretty straightforward. My patient's got pancreatitis, I've made the diagnosis, I've done the tests, I've started the treatment. All that we need to do now is refer them. So let's see how that goes. Hey, switch. Yeah, can you page gastro for me? That'd be great. Oh, hi, I'm Vic Brazel from ED. Who am I talking to? Yeah, gastro, I know, but what's your name? Oh, great, thanks, Pete. Look, I've got a patient that needs to be admitted. He's, Oh, I'm sorry, Switch told me you were on call, but, okay. All right, well, yes, look, this is a 45-year-old man with pancreatitis. He's presented with the lipase, 4,000. Yeah, so he's got a history of alcohol abuse. He's got another antibiotics. Sure, I can do that if you want. Anyway, this man has had previous episodes here. No, he's always been admitted by gastro. You want what test? How do you spell that? It's just not on the EMR order set anywhere that I can see. You want me to ring your resident to order the test? Hello? Hello? Yes, the problem is obvious, isn't it? It's those other doctors. It's the ones on the end of the phone. The problem is clearly obvious. I mean, we replay these conversations in our heads for hours and days afterwards, don't we? We know that we suffer from the psychological trauma of it. We actually know that our patient care suffers from it. We complain endlessly to our colleagues in the tea room. And we cannot understand why they are still working here. So, yes, of course we've all worked with a difficult doctor, haven't we? Yes, it's obvious. But maybe it's not so obvious. And when I was thinking about this, I took a little bit of a look in the mirror as well. I'm going to replay another simulation, a shorter one, that we might imagine happened a little bit after this. And this isn't even a simulation, it's a reenactment of a real day at my work some time ago. And I want you to imagine that now, sitting in that chair, is a medical student who's arrived for their shift. And you know the look, don't you? He's young, he's enthusiastic, he's looking around him at the excitement of the emergency department and clearly expecting a wonderful day of learning all the things there is to learn. And here I am, the consultant on shift. I'm the professor of emergency medicine at his medical school. I have a career-long interest in medical education. Clearly, this interaction is going to be me giving him utopian learning experiences and showing off the superstar emergency physician role model that I am. So this is how it went. Mate, that's my chair. Yeah, maybe, just maybe, we're all a little bit toxic every now and again. So maybe this is the more interesting question. Maybe it's just me, but I'm going to suggest that probably a few of you have just been a little bit toxic from time to time. So I thought, in the spirit of sharing some vulnerability, I might ask you to just spend a minute talking to the person next to you about a moment that maybe you were just a little bit toxic. So take your minute now. All right, that is your minute. Hopefully there were some highlights there of toxicity. So it seems like perhaps I am not the only one. But I think it's very tempting to think that this is not a problem that we have, that in fact it is those other doctors, because we have, perhaps justifiably so, a reputation for being pretty nice people. But interestingly, we've done a little bit of work on that, and this is work led by Eve Purdy, who's here in the audience, which actually looked at, in our emergency department, the relationships and culture within and between our teams, and the impact of that on performance. And to be fair, a lot of it did suggest we were pretty nice people who were team-focused and solution-focused. But we also had some notable exceptions and some varying perceptions of that. Some of it was like this, but some of it was different. And then more recently, we've been doing some work with our middle-level registrars and nurses, and one of them has gone out of their way to actually go and canvass the thoughts about leadership, both medical and nursing, in our department. And again, there are a few surprises. Again, I'm getting the sense people are recognizing these. And turns out it's not just us. If you really want to read one thing about this topic, this is the article to read. Liz Crow and her colleague Christine Riley put together an amazing resource in this article. It's full of references, and it relates to the extent, the etiology, and the impact of unprofessional behaviour in healthcare. Now, if you do want the too long didn't read version, it's this. And that is no surprise to people that work in healthcare. We've seen many people trying to do various high-quality interventions to try and fix this, but it does remain endemic. So why does it matter? Well, we know it matters to us, don't we? We know that we learn less as trainees in the face of unprofessional behaviour. We know that we're likely to suffer psychologically, both at work and at home, when we're exposed to unprofessional behaviour. And we know that we're more likely to leave work for good as a result of unprofessional behaviour. And these things are important. And in fact, it's things like even eye-rolling and low-level unprofessional behaviour that causes these impacts. But of course, the main reason we need to be concerned about this is because it affects our patient care and our performance. And again, a quote from Liz's article. So what do we do? Now, I'll tell you what this talk is not about. This talk is not about teaching you to speak up for safety. This talk is not about teaching you negotiation tactics from the Harvard Business School. This talk is not about teaching you the scripts for dealing with microaggressions. Those things are actually quite helpful, and I'm sure that they're good things to do. But I'm going to come at this from a different stance. And that is that powerful solutions to this problem lie within the team. Now, I don't play a lot of rugby. I don't even follow that much rugby. But this is a team called the All Blacks, and apparently they do all right at rugby. And they have a pretty famous saying about what they expect of each other. It's the no dickheads policy. And they talk about what that means to them. They talk about the expectations of behaviour so that they can perform as a team. And they invite and give peer feedback when those expectations can't be met. So these powerful solutions potentially come from the team. And the other way of thinking about this, and again, this is from Liz's article, is that it is the people around us that set those expectations and can hold us to account in a way that it's very difficult for the system to do and extremely difficult for the victim to do. So what does that mean? So here I'm going to share maybe what I've been trying to do about this over the last 10 years, because I gave a talk a little bit like this about 10 years ago about toxic incivility in healthcare, and I guess it's easy just to say, yeah, it's bad, but what are we going to do? So over the last 10 years, myself and a group of people have started a high-performance teamwork strategy at the Gold Coast. And I guess you might say, even though this was long before it was on TV, we took some inspiration from Ted Lasso, because our approach is one of coaching. And maybe a bit like Ted Lasso, we coach some teams that we don't even know how to play the game. But we know a lot about the interactions, the relationships, and the culture, and how they might affect performance of the team. And so there's some similarities in what we do. So I'm just going to go through a few of those examples about how we've done that, not as necessary an exemplar, but as a way of thinking about how important the team is in addressing these toxic leadership behaviours and addressing the problem of unprofessional behaviour. So we are a small but committed team with a fairly unique skill set. And we started our work in a couple of the usual suspects that are familiar to people like us, looking into teams who look after patients who suffer major trauma, and also maternity teams who are looking after women who've had a postpartum hemorrhage. We then expanded our work into other areas, including others outside of our health service at Gold Coast, and more recently have started working with teams who are coming together because they're going to work together in new spaces or new hospitals. Common to all these contexts is our strategy and belief that team behaviours obviously influence team outcomes, and leadership is one of those team behaviours. There are others. But that fundamental to any of those behaviours are the values, beliefs, and attitudes that underpin those behaviours. And that is the place where we like to think we do our work. So I want to give you a couple of the examples of those. And the first one of those was something we've been working on for 10 years, and that is major trauma care, a place where probably some of us have seen and maybe even perpetrated some toxic behaviours. And so for the last 10 years, we've been doing simulations and other work that has helped our teams come together, think about their work, and explore their relationships and culture as it pertains to their work and to their performance. And then when the anthropologist came to town, we actually formalised this with a little bit of research, looking at what we were doing and its impact. And as I said, a lot of this was about simulation, bringing together people from anaesthetics, surgery, ED, and the trauma service to think about how we all work together in this room and beyond. Of course, a lot of this was deconstructed in these kind of rooms, in a debrief room where we talked about, sure, what we needed to do in terms of our system improvement, our teamwork behaviours, but also what our expectations were of each other in terms of our behaviours. Shared problem solving is part of that, thinking together about how we're going to get to the CT scanner safe and fast. Yes, that is an inflatable CT scanner. I can talk to you later if you want one. We also talked with the surgeons about things that were unfamiliar to them, like doing damage control surgery, because most of them wanted to do a definitive procedure when this might have been the more appropriate thing in the moment. And more recently, we've been able to extend our reach much further because we've looked at new formats of getting our team together and team training, which we've discovered are nearly, if not more effective than some of the things we were doing in the trauma room with our mannequins. And this is the feedback we were getting from people about the impact of this work. They said a few things, like we learned what the dose of rocuronium was, but these were the impacts that were much more salient when we investigated that. So our Director of Trauma is a surgeon, and he was interviewed by our national newspaper during this period and about just the trauma service in general and its outcomes, and this is what he said. So this is a pretty powerful bystander effect. So then we had a similar approach when a few years later we were asked to work with the teams who looked after women who suffered postpartum hemorrhage. And again, this is a time of high stress. It's certainly a time when there are differing worldviews sometimes about what should happen with the patient. And it is a time when relationships and culture are going to be crucial. And once again, thinking about how we could take a coaching approach to that to help people explore their work, to understand how relationships and culture underpin their behaviours and how that would ultimately lead to better performance. Some of this work actually involved a mapping of the relationships and the strength of the relationships between different groups of staff who were involved in the care of this woman. And you can see it's usually a bit more complex than we might think. It's not just doctors and midwives. There's a variety of different people at different levels with different interests and different paradigms about how they're thinking about the care of this woman. So we spent some time in simulation, but that was actually only a relatively small part of the work that we did with these groups. We spent as much of it in our debrief rooms, and the people in yellow there are the women who work in blood bank. Who'd have thought Penny had a face as well as a name? And so we spent some time actually talking about the care that these groups were providing with the people who were involved. Once again, we've been able to leverage that through running short, sharp team training exercises where people will talk through their work and what they expect of each other during that work. If you've ever seen a midwife who's simulating getting to the operating theatre with a cord prolapse, they get up on the table. And so we, again, looked at this and we had pretty good relational outcomes. That was no surprise to us because that was what we were working on. But with this group, we also tracked the clinical outcomes of the teams and the work that they were doing. The wide blue bars there are the numbers of deliveries over years. So as you can see, We are very fertile on the Gold Coast, more and more people being delivered. But the thin, darker blue line there is the percent of the deliveries who have a large postpartum hemorrhage, which is a pretty good indicator of how well the early postpartum hemorrhages are being looked after. So pretty dramatic. That was a 44% reduction in large postpartum hemorrhages over that period of the study. That said, of course, when you get up here, you tell a few good stories about your successes. We still have work to do. There are some people in that group who truly I have experienced as toxic leaders. And despite all of this, including some sessions that we run specifically for the senior midwives and obstetricians, talking through their relationships, which are even called productive disagreement, recognizing that we have areas of conflict together. One of those obstetricians who walked out of the session sent this to his WhatsApp group of consultants afterwards. MWs are midwives. So we do still have a way to go. All right, well, we're coming up to some questions soon, so I guess you're wondering, what can I do tomorrow? I haven't got a high-performance teamwork strategy. I haven't got 10 years to do this. What can I actually do? Well, the reality is that we can do maybe more than we think. And one of the things that this study powerfully showed us in our own emergency department is two of the factors that have the biggest impact on our performance and on our culture are leader behaviour and team familiarity. So every time you are sitting together having a reflection on your shift, that is building some safety and some culture in your team. Every time you do a pre-briefing before a trauma and you set some expectations, that is building the culture in your team. So there are many things that we can do as individuals that help to contribute to this, not just by being better people, but by thinking about the role of the team in helping us to build that culture. We did get some good stuff when some people looked at this recent work that one of our colleagues did asking about leadership in our department. So you can see the impact that the positivity has. I don't know if they actually saw twice as many patients, but they felt like they did. So my thoughts, and I'm interested to hear yours, is to actually just get some explicit conversations going about the expectations we have with our teams. Our role as an upstander and just gently reminding people about those expectations is important. And maybe, just maybe, every now and again, check in the mirror for ourselves. Thank you very much.
Thank you very much, Dr. Brazel. It's a very reflection-worthy presentation. There are 4 microphones amongst you, so you may just stand up and ask your questions. There's one coming. Good.
Thanks, wonderful talk, really engaging. And I'm wondering if you could give us some strategies for that consultant who we all know in our shop, who you can predict is going to cause you that problem behavior on your shift. You know that if you need to consult them, it's going to be a mess, right? Because it is every time. And they don't want to see that patient, or they want you to do things that you don't perceive is your job. And the whole team can kind of feel that if we need to get this person involved, it's going to be a problem. How can we cope on that shift with that consultant in order to turn the tides even a little bit?
I don't think you can. I think the solutions, I'm quite serious, I think the solutions to that problem lie in the team that they work in possibly as much as yours, and the system that has allowed that behaviour to be perpetrated. And I know that's a glib response, but I know there's plenty of people who do teach negotiation tactics, but I feel like that is very flawed. If we are trying to help the victims
Yeah.
deal with perpetrators, then I feel like we're just feeding into that same mission. So I do think we have to say, if that is truly the case, and that is so predictable, then I think we have to ask the people who employ this person that. And I think if you look at the literature, and again, Eve has helped with this, bad apples just can't be dealt with in the moment. And they have the potential, just as you indicated, to infect the whole feeling on a shift, the whole feeling around a patient episode. And so I'll stand by that. I don't think we can fix this in the moment.
So, I'll push just a little bit there, and I'm wondering if you have tips and tricks then for how us, maybe the emerge doc who just wants to do a good job and wants our team to have a good night shift. Is there any tips for the team in order to minimize the impact of that toxic individual on the rest of the team and on you and your night shift, say?
Yeah, so I think if you are one of the people with power, this is your chance to be an upstander. And so I think this is your chance to make sure that those who are definitely more predisposed to being the victims of unprofessional behaviour, and we know who those are. They are the usual suspects, people who are junior, people who are in minority groups for whatever reason. Women are definitely more likely to be victims than men. So I think if we are people with power, we have got the responsibility to make sure we are doing the assertion of the expectations of behaviour with someone who might be behaving like that. So yeah, it's the chance to be an upstander.
Thanks. Thanks very much.
Thank you.
All right. So maybe just to differentiate, can we really differentiate a doctor who's just having a bad day or there's really a pattern of toxic behavior?
Yeah, absolutely. I think it is an important distinction. I would like to think my comment to the medical student was me having a bad day rather than a pattern of unprofessional behaviour. That's what I would like to think anyway. And I think that is the case, and I think that is even more important than to think about the team, because it is our friends, in fact, who will help us say, you know what, that wasn't a great thing to do, you should go and say sorry. And in fact, that goes a long way to also helping build culture. Actually, having some conflict, but then repairing it productively can be at least as good as ignoring conflict and unprofessional behaviour. So I think someone having a bad day is very different, and it's still amenable, I think, to the team saying, mate, not quite.
I think we still have time for questions. Yeah.
Thank you for a great talk. In your last slide, you said that you talk to your teams about expectations. So what's the fine line you decide that they are not over-expecting things from you? And how do you decide that, okay, I need to put a hold on this, and then, you take their suggestions that what they expect out of you, but there are certain times there are people who try to be loose, they try to lose up. So how do you decide that they are not over-expecting things, and how do you control that?
I guess I'll try and give a specific example, but let's say you were doing a pre-briefing for a resuscitation case coming in. We're very used to that pre-briefing being task-focused. We're going to get this patient, we'll probably need to do this for them, these are the things we might need to get ready. I would suggest we add a couple of sentences, and this is how I think our team communication will run. I expect this will be stressful for us, so if anyone feels like that's the case, we still want people to not get too heightened, and if you need to step out, that's fine. And I also expect everybody else to help each other. So setting some expectations about what we want from the team in terms of their communication, what's appropriate, what's not, and how people can help each other, I think can be part of a pre-briefing like that.
Thank you.
Victoria, there are two situations. One, you've got a person who is either a consultant or registrar from outside the department coming in, and the other one would be what we call visiting medical officers, who are contracted staff for various shifts versus the staff specialists who are actually they're employed by the hospital. How do you deal with these particular situations? Obviously, if you had the power, yes, but at that particular time, you've mentioned some of the strategies. Can you expand that a little bit further in terms of how you would politically have power to resolve or resolve these situations?
Yeah, so I take your point. And through the work that we've done, we spend a lot of time with quite senior leaders who are very frustrated with some of the people that we're talking about, because they have tried, and it is quite hard sometimes within our health systems to sack people, basically, or otherwise stop them being employed. That said, I think that is where a lot of the solution lies, and one of the things about the work that we've done is it is quite granular. It relates to the work that people are doing. It's not just complaints about attitude or these sorts of things. We can actually provide, when people do this, this is the impact, and this is what the other staff tell us. So I think there's a whole variety of employment relationships, but one of the really good things in Liz's article is that it says that many of the perpetrators of toxic behaviours, they are powerful people, they have strong social skills, and they often have a skill set that is desired by the organisation, and their behaviour is an assertion of power that works for them. So if you think about this, we have to somehow break the chain of that. And I think if that means we've got some expectations of behaviour, we should say that. And I know that that will create some inconvenient challenges for administrators about, do you have no doctor or a toxic one? But I would like to think that we can make those decisions, because we kind of have to, because the impact is so enormous on the patient care and on all the other staff that I think it's time we probably just said, when it's at that point, that's enough.
Good, thanks.
Yeah.
Questions, and we can continue. Just asking if Dr. Hitti is here. We'd like to have her present at the AV counter, but please keep going.
All right.
Okay. Maybe for a while.
Maybe we'll have more time for just one question before we wrap up. Okay? Sir?
Raj.
Yeah, thanks, Vic. It's always such a treat to hear you speak, so thanks for a great talk again. I think one of the important things you pointed out was to bring this back to the work unit level again. You know, we talk about the bigger approach to these things. And we know that from what you've said, that the relational component, Kim Scott speaks of this in Radical Candor, that we need to put in the emotional labor to then be able to have these difficult conversations. And, you know, with receiving feedback. My question is just, do you have any tips on how do we get executive buy-in into, this is where we should be putting our energy and some of our resources into including this in our work time. This is a component of our work, especially in the emergency where we work, and it is high stakes and it's high pressure. You know, how do we get them on board? And just a little add-on to that, doing initiatives like Schwartz rounds, you know, help with giving us this perspective of our colleagues, interdisciplinary colleagues. And, you know, and one last bit is receiving feedback. We're not always very good at that. So I know in our place, that's something that we're going to be working quite hard on. And we're needing external help with that. But how do we get our, especially more senior colleagues, to take that feedback on board and just make it part of our normal day-to-day work? Thanks.
Yeah, I think that's 3 questions. But yeah, thank you, Raj. So the first one about executive buy-in. Look, I think executives are bought into this. I think, in fact, at the top levels, they know the impact of this kind of unprofessional behaviour, but often don't have ways to examine it, operationalise it, and deal with it. I think at the next level down, like department level leadership, sometimes we've got more opportunities than we think, because we spend some time doing other things, and I won't mention them by name, but people going off to various kinds of training activities that probably aren't effective at moving the needle on this agenda. And so I think it's probably time to say no, sending people for 4 hours to this particular workshop that's going to teach you how to speak up to the aggressor probably is less helpful than saying, no, why don't we actually work together as a team and spend some time looking at our care of head injuries, but let's also talk about how our behaviour in the trauma room when they arrive will be important. So I think executives are bought in, and in fact we have found that we get pointed at difficult teams to go and do some work with them. So I think that is sort of, that engagement wasn't that hard. Things like Schwartz rounds, yeah, I mean, any opportunity where you've got people prepared to come together and have some reflections like that. The trouble with that is, of course, most of the most toxic individuals don't actually go to those sorts of things. And the third question was feedback, yes.
Receiving feedback.
Yeah, I mean, we are not very good at feedback. I personally like feedback that comes in the form of fawning, and I don't think I'm alone in that. So I think that is also a cultural shift, and it also, in some places, is a form of words, people being able to articulate the feedback that needs to be had. But finding times, places, and spaces, and there's many of experts in the room on this, I think we can say culture is one of those things we can also feedback about.
Thank you.
Great.
Thanks, Raj.
I'd like to, fantastic. Victoria, I want to thank you for sharing your experiences and knowledge with us today. It was just fascinating. We can all certainly bring back some of the key points back to our hospitals for our next shifts. Pauline, many thanks for moderating this session. On behalf of the conference, we have a gift for the both of you. Everyone, please join me in thanking Victoria and Pauline.